بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا. Dear colleagues, this is the second lecture in the series of head and neck imaging. It will deal with the sinonasal imaging. We will start by the anatomy and the scanning techniques, and you know that we have two main types for CT imaging of the paranasal sinuses. The first study is known as the routine study, which is performed in the coronal view or position. The patient is in the prone position, and we have the scanogram in the lateral view. Then we specify the area to be examined from the posterior wall of the cella, or from the dorsum celli, or from the posterior wall of the sphenoid sinus, and we proceed anteriorly until we reach the anterior wall of the frontal sinus, and the scanning interval is usually 3 mm. In this study, we do not inject contrast media. We use only the bone window images for delineating the anatomic details of the paranasal sinuses. Then the second study is known as the full study, and this means that we have axial sections and coronal sections, as well as sections for the brain, and in most of the cases we need to inject a contrast media. This full study is usually directed for evaluation of paranasal sinus inflammatory and neoplastic pathology. For the axial images, we have the patient in the supine position, and we have the scanogram in the lateral view. Then we specify the area to be examined from the level of the hard palate, and we proceed upward until we finish the frontal sinus. This is the axial images, also at 3 mm intervals. Then we scan the brain from the base of the skull up to the vertex at 1 cm scan intervals. Then in the paranasal sinuses, the full study, we usually have the soft tissue window and the bone window images. And for anyone who is not in the radiology practice, this is the difference between the soft tissue window and this is the bone window. In the soft tissue window, you can see the details of the soft tissue structures, and in the bone window you can see the details of bone and bone-like lesions. When you see it, this is a paracellular chondrosarcoma with calcium inside the matrix of the tumor, and it affects the greater wing of the sphenoid, as well as maybe the petrous apex. And this is actually the difference for anyone who wants to know the differences between the soft tissue window and the bone window. Then we may have to reconstruct the images in 2D or 3D planes, and this is a good example for 3D images of the maxillofacial area. And you should remember, in my opinion, that the 3D images are of little value, of little diagnostic value, except in the cases of maxillofacial trauma, as I will explain this in full details in the lecture of maxillofacial injuries. And in the paranasal sinuses, we want to discuss these issues. We want to have some knowledge about the anatomy. Then I will show to you some examples of acute sinusitis, chronic sinusitis, the retention cysts, the sinonasal bulbosis, the antrochoanal polyp, mucoceles, fungal sinusitis, and finally I will finish by the benign and malignant neoplasms of the paranasal sinuses. Starting by the anatomy, and this is the axial images. We start at the level of the hard palate. Then you see the root of the maxillary sinus on both sides, and this is the ramus of the mandible, and this is the styloid process. The anatomy of this area will be explained in full details in the lecture of imaging of the parapharyngeal spaces. Then this is the maxillary antrum on the left, and this is on the right, bony nasal septum and mandibular ramus, styloid process, and the pterygoid blades. Then going up, then you see the maxillary sinus, the pterygoid blades, the mandibular ramus, and the styloid process. This is the bony nasal septum, and this is the start of the inferior nasal concha. Then inferior nasal turbinates, maxillary antra, this is the nasal bones, and here is the pterygoid blades, the medial and lateral pterygoid blades. This is the zygomatic bone, and this is the coronoid process of the mandible, and this is the head of the mandible, or the condyloid process. Then more up, you see the maxillary antra on both sides. This is the nasal septum, nasal bones, and this is part of the zygomatic arch. Then here you can see the full course of the zygomatic arch. This is the head of the mandible in the region of the temporomandibular joint, and this is the maxillary sinus on both sides. Then you proceed up, then you see the end of the maxillary antra and the start of the ethmoidal air cells, and this is also the sphenoid sinus, and here you see the petrous bone on both sides, and the ethmoidal air cells and the sphenoid sinus. And finally you reach the frontal sinus. This is the left one and this is the right one, and you can appreciate this bony mass inside the frontal sinus, which represent a small osteoma in the frontal sinus. The coronal scans start from the posterior wall of the sphenoid sinus, and here you can see some septations inside the sinus. Then as you proceed anteriorly, then you see the sphenoid sinus two compartments, and this is the skull base, and these are the region of the pterygoid blades. Then you go more anteriorly, this is the sphenoid sinus on both sides, and this is the nasal fossa, bony nasal septum, inferior turbinate and middle turbinate. Then you go more anteriorly, the nasal conchae, inferior turbinate, middle turbinate, sphenoid sinus on both sides, and here is the orbital apex, and this is the superior orbital fissure, and this is the inferior orbital fissure. Then you go more anterior, these are the ethmoidal air cells. This is the bony nasal septum, inferior turbinate and middle turbinate, maxillary sinus on the left and maxillary sinus on the right. Then you proceed also more anteriorly. Then you see the nasal turbinates, the bony nasal septum, ethmoidal air cells, and the start of the pneumatization in the front, the orbital roof, which is considered part of the frontal sinuses. And here you can see the ostium of the maxillary antrum on both sides, and you see the orbital cavity, the pneumatization of the orbital roof, and this is the maxillary sinus, and here is the bony nasal septum. This is the inferior turbinate, and this is the middle turbinate. And you go more anteriorly, and you reach the most anterior part of the maxillary antra, and also you reach the frontal sinuses. This is the bony nasal septum, and this is the agar ala nasai air cell. Then we would like to have some more details about each of the sinuses, starting by the maxillary antrum. And here, this is the maxillary sinus, and this is the outlet of the maxillary sinus as indicated by this line. The maxillary antrum has an osteomeatal complex unit, which is formed of 4 parts, and these parts are the site of the maxillary antral ostium, then this passage, which is known as the ethmoid infundibulum, then this curve, which is known as the hiatus semilunaris and ending by the middle nasal fossa. If you look carefully here, and you see this is the orbital floor, and this is the inferior medial aspect of the orbital wall, which will form the lateral wall of the ethmoid infundibulum. Then this bony process is a famous one, is known as the uncinate process. Then if you look carefully here, then you see this is the site of the ostium, and this is the ethmoid infundibulum, hiatus semilunaris, ending by the middle nasal fossa. Then this arrow points to a foramen which is located in the orbital floor, and this is known as the infraorbital canal, where the infraorbital nerve and artery pass through this foramen. This is once more the anatomy of the maxillary sinus, and the site of the ostium, the ethmoid infundibulum, and you go to the hiatus semilunaris ending into the middle nasal fossa. This is the inferior turbinate, and this is the middle turbinate. Then this red arrow points to the site of the maxillary antral ostium, and this is the ethmoid infundibulum, and here is the hiatus semilunaris, and this is the middle nasal fossa. This process is known as the uncinate process, which is the medial wall of the ethmoid infundibulum. The lateral wall is formed by the bony orbit. Then if you look carefully here, and you see this is the maxillary sinus antrum, and this is the ostium, this is the ethmoid infundibulum, hiatus semilunaris, and the middle fossa. Then if you magnify this and you look at this passage, and this will form the ethmoid infundibulum, which connects the maxillary antral ostium to the region of the hiatus semilunaris, and finally to the middle nasal fossa. The ethmoid sinuses is formed of three parts, and the horizontal part, which is the famous bone known as the cribriform plate of ethmoids. It has two components, a small part on the left and a small part on the right of the midline. The vertical part is known as the crista galli, and this is also part of the ethmoidal complex. Then the ethmoidal air cells, which are divided into two parts, the anterior ethmoids and the posterior ethmoids. They are separated from the orbit by the medial orbital wall, which is known also as the lamina babricia. Then the gyrus rectus as well as the olfactory bulb are anatomically located in this area, in this depression between the crista galli and the superior plate of the ethmoidal air cells. Then you know that we have two groups of ethmoidal air cells, the anterior group, which are numerous and the smaller cells, and the drain in the middle meatus. The posterior group are larger and fewer in number, and drain in the superior meatus. Then one of the well-known cells in the ethmoids is known as Onodi cell, and this is the largest cell in the posterior ethmoids. Its importance lies in its close relation to the optic canal, and any surgery here should be done very carefully in order not to injure the optic nerve, which passes very close to this Onodi cell. And this is a cell which is considered as an anatomic variant. It is pneumatization of the inferior medial part of the orbital floor, and this is known as Heller cell. This Heller cell is intimately related to the osteomeatal unit. You know, this is the ethmoid infundibulum, and this cell will encroach on the ethmoid infundibulum, and sometimes if it is so large it can obstruct the ethmoid infundibulum, resulting in retained secretions within the maxillary sinus. Then the ethmoid bulla is the largest ethmoidal air cells which lies close to the ostium. And if you look to this diagram, and this is the ethmoid infundibulum and the maxillary antral ostium, and this large cell in the ethmoidal air cells which is very close to the osteomeatal unit is known as the ethmoid bulla. Then here you can see that there is pneumatization of the orbital floor, which is known as Heller cell, bilaterally on the right side and also on the left side, encroaching on the osteomeatal unit. Then if you look carefully here, and you see this is the inferior turbinate and this is the middle turbinate. The middle turbinate is attached superiorly to this part of the ethmoid, which is known as the cribriform plate of ethmoids. Then if you see here, and this is the crista galli, this is the cribriform plate of ethmoids, and this part which is a bone that is very thin, which is bordering the gyrus rectus and the olfactory bulb from the lateral aspect, is known as the lateral lamella or the fovea ethmoidalis. This bony plate, which is very thin compared to the rest of the thick bone distal to it. Then this is the lateral lamella and is also known as the fovea ethmoidalis. Then the middle turbinate is attached to the lamina papricia. This is the middle turbinate, and this line will connect the middle turbinate to the medial orbital wall, which is also known as the lamina papricia. This connection is known as the basal lamella, and the air present between the basal lamella and the ethmoid bulla is known as the sinus lateralis. And if you look carefully here, then you see this is the ostium of the maxillary sinus, and this is the ethmoid infundibulum, hiatus semilunaris, and middle fossa. Actually, this anatomy, including the basal lamella, the sinus lateralis, the lateral lamella, is of importance for the surgeons, because this will delineate and demarcate certain anatomic areas to be handled if they are working by the endoscope. But you should know that the basal lamella is the septum which divides the ethmoids and into anterior and posterior ethmoidal air cells. Then whenever you ask about the line of separation between the anterior ethmoids and the posterior ethmoids, it is the basal lamella, which is the line connecting the middle turbinate to the medial orbital wall. And this line is of course not constant. It can be seen in some cases and cannot be seen in others. And in this is the middle turbinate, and this is the connection of the middle turbinate to the medial orbital wall, and this is known as the sinus lateralis. This air is known as the sinus lateralis. Then we came to the frontal sinus, and the sinus can be seen in the axial, in the coronal, and in the sagittal images. The sinus drains into the anterior part of the middle meatus here in this area. You know, this is the sagittal reconstruction, and this is the hard palate, inferior turbinate, middle turbinate, which is pneumatized. It's known as concha bullosa. I will mention it in a moment. Then this is the route of drainage of the frontal sinus through the anterior ethmoids into the middle meatus. Then the nasofrontal duct is a component of the anterior ethmoids. Then you remember, if there is ethmoidal fracture, it will involve the nasofrontal duct, actually resulting in obstruction of the drainage of the frontal sinus. The sphenoid sinus lies inferior to the pituitary fossa and superior to the nasopharynx, On both sides, the sphenoid sinus is related to the cavernous sinus. And sphenoid sinusitis is one of the known causes of cavernous sinus thrombosis in some cases. And here you see this is the frontal sinus, ethmoidal air cells, and this is the inferior turbinate and the middle turbinate. The sphenoid sinus can be hyperpneumatized with extension of the pneumatization into the skull base as well as into the pterygoid blades. Then you see an example where the pneumatization of this sphenoid sinus extends into the skull base and the root of ethmoids. The sphenoid sinus drains through the sphenoethmoidal recess. This area is known as the sphenoethmoidal recess, which is clearly seen in the sagittal images. It drains posterior to the superior concha. If you look here, this is the inferior turbinate, and this is the middle one, and this is the superior one. The sinus drains posterior to the superior concha here. And this is an example of hyperpneumatization of the sphenoid sinus extending into the skull base and the root of the pterygoid on the right side. It may also involve the pterygoid blades as well. Then some of the normal variants, first concerning the nasal septum, which this is a very common situation, deviation of the bony nasal septum to one side or the other, pneumatization of the posterior part of the bony nasal septum, and you see here air within the nasal septum, and this is known as bony spare of the nasal septum. You see this part of bone connected to the nasal septum obstructing the nasal fossa on the left side. And this is also an example of bony nasal septum spare to the right side. The septum is a little bit deviated, and you can see the bony spare projecting into the right middle, the right nasal fossa. The middle turbinate, this is the normal appearance, and you remember the attachments to the cribriform plate of ethmoids superiorly. This is the fovea ethmoidalis or the lateral lamella. The middle turbinate can be pneumatized and is known as concha bullosa. And this is an example. Concha bullosa can be unilateral or can be bilateral, can be symmetric or asymmetric, one small and the other one is large. And this is an example of pneumatization of the crista galli and pneumatization of the middle concha on the right side with marked deviation of the nasal septum to the left side. And this is an example of bilateral pneumatized concha bullosa, a smaller one on the left and the sizable one on the right side. The concha bullosa can be infected similar to the sinuses. Then you'll see that air will be replaced by secretions. Then you know that this is concha bullosa that is secondary infected. And one of the variants concerning the uncinate process is that it can be pneumatized. The uncinate process, similar to any part of the bony outline of the paranasal sinuses and the nasal fossa, can be pneumatized. Then medial deviation of the uncinate process will result in obstruction of the antral drainage. Lateral deviation of the uncinate process will result in obstruction of the middle fossa. Then we have an abnormality which is related to the uncinate process, is known as atelectatic uncinate. And this atelectatic uncinate is adherent to the inferior orbital wall, leading to obstruction of the related maxillary sinus, and this will result into the sinus will be relatively smaller, it will be opaque, and also the orbital floor will be low-lying or bulging towards the uncinate process. Then at the time, the only way for evaluation of the paranasal sinuses was the routine plane radiographs, especially this water view, which is known also as the sinus view. And this sinus view was helpful in screening for sinusitis, looking for some cases of maxillofacial trauma, also detecting intraorbital or maxillofacial foreign bodies in cases of trauma, preoperative planning, and it was sometimes helpful in assessment of dental disease. And these are some of the radiographic signs of paranasal sinus diseases, including mucosal thickening, which will appear as a concentric line encroaching on the antrum, for example. Air fluid level, as you can see here, which is an indication of acute sinusitis. Total opacification of the sinus, erosion or destruction, or bony sclerosis, the presence of calcification, the presence of foreign bodies, and fracture lines as well. Then starting by the first disease in this category, which is sinusitis, and we have two types: acute sinusitis and chronic sinusitis. We usually diagnose acute sinusitis by the presence of air fluid level in the affected sinus. And this is an example, a good example of acute sinusitis by plain X-ray, and this is acute sinusitis by CT coronal view, and you see the air fluid level. Then the difference between acute and chronic sinusitis is that in chronic sinusitis you got concentric or boloboidal mucosal thickening of the affected sinus or sinuses. And you see here mucosal thickening in the frontal sinuses, denoting chronic sinusitis. Then it's important to know that the mucosal thickening in the nasal cavity and the anterior ethmoidal air cells, as well as in the concha, may be considered normal as a part of the nasal cycle. And also in children, don't diagnose sinusitis based solely on opacification of the sinuses on the CT scan, for example, or X-ray, but you should have a good clinical support before setting down this diagnosis. Acute sinusitis by MRI will show fluid signal in the affected sinus, which will be dark in the T1 and bright in the T2 weighted image, as you can see in this example. And this is chronic sinusitis with concentric mucosal thickening of the maxillary antrum on the left side. It shows fluid signal in the T1 and high signal in the T2. And if you inject a case of sinusitis with contrast media, you will get marginal enhancement, which is almost similar to that seen in any inflammatory process. And one of the manifestations of chronic sinusitis, beside mucosal thickening, is the bony sclerosis of the affected sinus. And here you can see that the left compartment of the sphenoid sinus is totally opaque, and the walls of the sinus are thickened and sclerotic. And this is a case of chronic sinusitis diagnosed by concentric mucosal thickening of both maxillary antra and extensive mucosal thickening in the ethmoids. And you may see also and feel that there are some bony sclerosis of the antral walls. Then this disease is known as silent sinus syndrome, which is the sequelae of chronic occlusion of the maxillary sinus ostium, which will result in gradual resorption of air and subsequently negative pressure within the sinus. This will result in progressive loss of volume of the sinus itself, and at that time it will be totally opaque. Then you see this is the maxillary antrum on the right side compared to that on the left side, there is considerable loss of volume. The sinus is opaque, and in the bony margins may be sclerotic. In silent sinus syndrome is just a gradual occlusion of the draining ostium of the maxillary sinus, resulting in absorption of air and the gradual loss of volume of the affected sinus, which will be totally opaque. Then retention cyst is a bulboidal lesion within the sinuses, most commonly seen in the maxillary antrum. And you see, this is an example. It is just an accumulation of fluid underneath the sinus mucosa, resulting in a bulboidal mucosal thickening. And remember that retention cysts are far more common than polyps in the sinuses. And in order to diagnose polyp in the sinus, there are some criteria I will mention. But whenever you see a single lesion like this in any of the sinuses, and you can call this as retention cyst. And this is a retention cyst by MRI, T1 weighted image, the fluid is black, T2 weighted image, the fluid is bright. And this is the situation where to say polyps. If you see that there are subtotal opacification of the sinuses by soft tissue masses that are continuous with masses in the nasal fossae, the masses are merging with the nasal turbinates, there are marked widening of the antral ostia and rarefaction of the bony margins of the paranasal sinuses, and we call this sinonasal bulbosis. And you consider the soft tissue masses in the nasal fossae as polyps, and also you consider those in the sinuses as polyps. This is what we call sinonasal bulbosis. It is an extensive opacification of the paranasal sinuses by bulboidal mucosal thickening, merging with polyps in the nose, also merging with the nasal turbinates. This is also an example of sinonasal bulbosis type, showing total opacification of the sinuses, widening of the antral ostia, bulky masses in the nasal fossae merging with the nasal turbinates. And this is an axial images for sinonasal bulbosis type of sinusitis. And you see total opacification of the maxillary antra, and you also see this mass in the nasal fossa on the left side. Then we came to the antroquanal polyp, and this lesion starts in the maxillary sinus, then it grows through the antrum into the nose and maybe also in the nasopharynx. The criteria for the diagnosis of antroquanal polyp: number one, a lesion inside the antrum, and the antrum needs not to be totally opaque, but you see a lesion in the antrum that is continuous with another lesion in the nasal fossa through the widened antral ostium, and this lesion may also project into the nasopharynx. And many say that the clearance of the ethmoidal air cells is necessary for the diagnosis and for differentiating this from another lesion which may simulate it, known as inverted papilloma, and I will come to it in the discussion of benign tumors of the paranasal sinuses. This is a antroquanal polyp. The sinus is opaque, the ostium is wide, the lesion in the sinus is continuous with another lesion in the nasal fossa, and this lesion is merging with the nasal turbinates, as you can see here. And this is an antroquanal polyp. The sinus is opaque, the antrum and ostium, the antral ostium is wide, and the lesion is continuous into the nose and also into the nasopharynx. You know that also the maxillary sinus has a secondary ostia, and this is one of them. This is opacification of the antrum, and the lesion is going through one of the secondary ostia into the nose and then into the nasopharynx. Diagnostic of antroquanal polyp. and this is antroconal polyp by MRI. This is the proton density image, and this is T2 weighted image. You see a mass in the antrum which is continuous with mass in the nasal fossa. Then we came to the mucoceles, and this means that there is obstruction of the drainage site of the sinus, resulting in retained secretion and progressive enlargement and rarefaction of the sinus bony margins. Mucoceles are very common in the frontal sinuses and less common in the ethmoids and least common in the maxillary antra. This is the normal appearance of the frontal sinuses, and here the left frontal sinus is clear, but the right one is opaque and is expanded, suggestive of a mucocele in the frontal sinus. And this is a CT scan, and this is MRI of two different cases showing expansion of the left frontal sinus with the rarefaction of the bony margins, diagnostic of frontal sinus mucocele. And this is MRI T1 weighted image post contrast showing expansion of the frontal sinus with bulging of its posterior wall intracranially, and as in any case of sinusitis and mucoceles, if you inject the contrast media, it will show marginal enhancement, and this can help to differentiate tumors from mucoceles, because tumors will show either homogeneous or heterogeneous contrast enhancement. This is also a third example of mucocele of the maxillary antrum. The antrum is expanded, the bony margins are relatively thin out, and this is classic for mucocele of the antrum. Then we came to the issue of fungal sinusitis. We have three types of fungal sinusitis: the allergic type, the fungal boil, and the invasive type. The allergic type is seen in immune competent patients and also in children. A fungal sinusitis may be unilateral or bilateral. And one of the basics for the diagnosis of fungal sinusitis is the detection of hyperdensities inside the opaque sinuses. And these hyperdensities are seen even without injection of contrast media. And this is one of the diagnostic criteria of the presence of fungus inside the sinuses. If you look carefully, you can see the difference between the secretions due to sinusitis, ordinary sinusitis, and the masses which are dense due to fungus. Then this is fungal sinusitis. This is the ordinary secretions, and this is the fungus itself. In order to diagnose fungal boil, you should see some calcium inside the fungus itself. And if you detect calcium, and you think of fungal boil. Then this is the sinonasal bulbosus type as seen in the routine coronal CT scan of the paranasal sinuses in the bone window image. But if you look at the soft tissue window image, and you can see the hyperdensities of the fungus, also you see the hypodensities of the sinusitis, and this is sinonasal bulbosus type of sinusitis that has been complicated by secondary fungal infection. In the invasive type, you got bone destruction, and this frequently seen in immune compromised patients, and you got invasion of the or destruction of the sinus wall. Then you got intracranial extension, intraorbital extension, and maybe also, if this is in the sphenoid sinus, you got cavernous sinus thrombose. Then this is a CT scan of an invasive fungal sinusitis of an elderly patient presented by brainstem stroke. In the CT scan, this is the axial soft tissue window after contrast injection, and this is the bone window. You see the sinus is obliterated and is also expanded. But if you look here for the MRI of the same case, and one of the criteria of fungus in MRI is the dark signal in the T2 weighted image. Then this is the fungus in the T1, which is of intermediate signal, and in the T2 weighted image you see the fungus of dark signal, compared to the bright signal of the ordinary secretions due to sinusitis. And many times if you inject fungus, it will show contrast enhancement, but in this example, the fungus does not show significant enhancement. And this is diffusion weighted image showing the main cause of the patient presentation, which is a brainstem stroke or acute infarction, of course, because of the intimate relation between the fungus and the basilar artery. Then if you look here, and this is total opacification of the sphenoid sinus, you are not sure to say that this is due to fungus, but an MRI T2-weighted image, and you see this very dark signal indicates the presence of fungus, and the surrounding bright signal is due to the ordinary secretions of sinusitis. Then in this particular example, whenever you see hyperdensities in the CT scan with or without contrast injection, and this is diagnostic of fungal sinusitis, and you can also appreciate the presence of fungus even in the bone window images by detecting these hyperdensities. And this is invasive, of course, because there is destruction of the sphenoid sinus floor, as you can see here in the bone window image. Then how can you predict the presence of fungal sinusitis from imaging? Number one, the detection of hyperdensities within the affected sinus on CT before or after contrast injection. Intrasinus calcification and marked loss of signal in the T2 weighted images on MRI. And sinusitis, which is resistant to medical treatment, you should suspect superadded fungal infection. And the maxillary sinusitis extending to the cheek, and this is one of the helpful clinical signs. If the patient is known to have sinusitis, then start to have facial swelling, especially in the cheek, and redness and the tenderness, and you think of the development of fungal sinusitis. Sinusitis has many complications, intracranial and intraorbital in particular. Intracranially, the extension of infection may result in meningitis, which will present by localized or diffuse meningeal thickening and enhancement, together with epidural collection like this one, epidural emboyema or subdural emboyema, or cerebral abscesses, which like this one with a rounded lesion with regular uniformly enhancing margin surrounded by significant perifocal brain edema, and also the cavernous sinus thrombosis if sinusitis is in the sphenoid sinus. This is an example of what is known as sinogenic epidural emboyema due to frontal sinusitis, and you got the pus, which is bordered by the thickened enhanced dura. Then orbital complications are usually the sequelae of ethmoid sinusitis, and this will result in spread of the infection through the lamina papyracea into the orbit. This may result in orbital cellulitis or subperiosteal abscess or even cavernous sinus thrombosis. And for the diagnosis of orbital cellulitis complicating sinusitis, you should see opaque ethmoidal air cells on the same side of orbital involvement. And this is an example. There is ethmoidal and maxillary sinusitis with collection of pus, which is marginally enhanced in the superior part of the orbit, diagnostic of subperiosteal abscess. And this is also a good example of subperiosteal abscess complicating ethmoid sinusitis on the left side, and you see the marginal enhancement of the abscess itself. Finally, we came to the tumors of the paranasal sinuses, starting by the benign lesions, and the most common is the osteoma. And the osteoma is the ivory solid osteoma without a cancellous or medullary cavity. This is a very frequent finding in the paranasal sinuses, especially in the frontal sinus. It can be diagnosed by the plain X-ray. You see a very big osteoma occupying the frontal sinus in the sinus view and also in the lateral view. And you can see this osteoma in the CT scan as well. The osteomas are usually asymptomatic, but it may obstruct the sinus drainage, leading to sinusitis. And this Gardner syndrome, which is a famous syndrome mentioned previously in the sector of colonic imaging, which includes multiple lesions. Some of them are the osteomas and colonic polyps. And this is a frontal sinus osteoma by X-ray, by CT, and by MRI. And you know that osteoma on MR will show very dark signal in the T1 and T2 weighted image because of the cortical bone containing non-mobile protons. And fibrous dysplasia is a developmental disease, which means that there is expansion of the affected bone and the ground glass texture of the bony matrix. This lesion is frequently seen in the orbital roof, but it can be seen also in the nasal septum or anywhere in the maxillofacial area. This is a good example of fibrous dysplasia of the maxillary sinus. The sinus is expanded, and you see the heterogeneous ground glass bony matrix in the affected sinus. And this is also a spot diagnosis of fibrous dysplasia involving the maxillary antrum on the right side. And this is the axial image, and this is the 3D image as well. Then we came to a benign lesion which is known as inverted papilloma. And inverted papilloma is a lesion arising inside the nose, and it can extend into the maxillary sinus as well as the ethmoidal air cells. This papilloma represents about 70%, 75% of sinus, paranasal sinus papillomas. It is of unknown etiology. It's common in middle-aged males, and it will arise from the lateral nasal wall. Then it will result in obstruction of the nasal fossa. It can extend, as I have said, into the maxillary sinus as well as the ethmoidal air cells. The sinus is usually widened, but this is not seen in many cases. But what is very important is the considerable expansion of the nasal fossa where the tumor is. Then if you look here and you see there is expansion of the nasal fossa, and this lesion may extend into the ipsilateral antrum. Then it may be mistaken for antrochoanal polyp, but remember that the antral ostium in antrochoanal polyp should be very wide, and the ethmoidal air cells are clear in cases of antrochoanal polyp. And this is a lesion which is arising inside the nasal fossa, and the nasal fossa is expanded. It may extend into the ipsilateral antrum and also in the ipsilateral ethmoidal air cells. This lesion is usually of benign nature, but in many times you can detect cells of squamous cell carcinoma inside the tumor itself. Then this is the difference between inverted papilloma and antrochoanal polyp. And you see the ethmoidal air cells are clear. In cases of antrochoanal polyp, they are obliterated. In cases of inverted papilloma, the nasal fossa is expanded. In inverted papilloma, it is not in antrochoanal polyp. The ostium is expanded in the antrochoanal polyp. It may be expanded also in the inverted papilloma. Then we came to sinonasal malignancies, which are considered rare lesions representing about 3% of the head and neck neoplasms, and 80% of all these tumors are of the squamous cell type. Then these lesions predominantly affected the maxillary sinus, about 65%, 20% in the ethmoids, and 15% in the nasal cavity. The clinical manifestations of sinonasal malignancies are usually similar to chronic sinusitis, but some additional features include rhinorrhea, facial pain, paresthesia, loosening of the teeth, exophthalmos, epiphora, and blood-stained nasal discharge. This is an ethmoidal carcinoma. There is a very big tumor mass centered to the region of the ethmoid, with aggressive destruction of the medial orbital wall on both sides, intraorbital extension, destruction of the anterior cranial fossa roof, floor, and intracranial extension, destruction of the nasal fossa, and the extension infiltrating the turbinates and the bony nasal septum. Then you can feel the aggressiveness of the mass in order to separate benign from malignant lesions. And this is a mass that has been eroded the anterior wall of the maxillary sinus as well as the zygomatic bone on the left side, also the nasal bone. And this mass has been proved pathologically to be a non-Hodgkin lymphoma. Of course, whenever you see a malignant lesion in the region of the paranasal sinuses, you assume the possibility of squamous cell carcinoma because it is more common. But whenever you see that the lesion is not that aggressive and the bone destruction is not that of a malignant aggressive disease, I will show some examples that you may think of lymphoma at that time. Here you see a mass by MRI T1 weighted image and MRI T2 weighted image is originating in the nose and the ethmoids, with consequent obstruction of the maxillary antral ostium drainage and retained secretions within the antrum. Then if you look to the contrast enhanced image, and you can appreciate the heterogeneous enhancement of the lesion. It is not just a polyp in the nose or just a mucosal thickening, but it's an aggressive destructive lesion. Also here you see that the antrum is opaque or obliterated by soft tissue density, which is continuous through the wide antrum into the nasal fossa, and you may think that this is an antrochoanal polyp. But if you look carefully here, after this is the axial T1 and this is T2 and this is T1 post contrast with fat suppression, and you see that there is a tumor mass heterogeneously enhancing that has obstructed the antral ostia, resulting in retained secretions within the sinus. Then the CT findings of malignant sinus disease include soft tissue mass affecting the sinus, which may show heterogeneous or homogeneous contrast enhancement associated with bone destruction of the affected sinus walls. Then the most common, as I have said, is the maxillary sinus squamous cell carcinoma, but many other malignancies can also occur in the paranasal sinuses, including lymphoma, melanoma, fibrous histiocytoma, fibrosarcoma, osteosarcoma, and even metastatic deposits. And this is an example of a big mass involving the maxillary sinus extending into the nasal fossa as well as in the infratemporal fossa, and this has been proved to be a maxillary sinus sarcoma. Then look here and you see this sinus is opaque with concentric mucosal thickening, and this sinus is totally opaque, and you may think of sinusitis. But if you look carefully and you see that there is a mass outside the maxillary antrum infiltrating the infratemporal fossa, obliterating this fat is obliterated here and is merging with the pterygoid muscles and also involving the masseter muscle, then the degree of bone destruction is not appreciated here. But this is not sinusitis. This is a neoplasm, and you may sometimes I will mention the value of diffusion weighted images in the head and neck in general, and also in whenever handling specific parts in the head and neck. But this is one of the examples, and here this is the MRI of the same case. You see mass inside the sinus and infiltrating outside the sinus and also in the cheek. This mass has restricted diffusion, being of dark signal in the ADC, diagnostic of being malignant, and this was confirmed by the marked uptake on PET CT. Then this was diagnosed after biopsy to be a large cell lymphoma. Maxillary or osteosarcoma in general can be seen frequently in the maxillofacial area, and the diagnosis is based on the detection of a lesion with malignant nature, meaning that there is invasion of the soft tissues around the lesion, destruction of the related bones, and if you can detect the classic sun ray speculations within some of these tumors, you may reach the diagnosis easily. Also, you know that some tumors can come to the paranasal sinuses from the adjacent parts, especially from the nasopharynx, which can invade the maxillary sinus sometimes, and also from the cranium, particularly from the sella. And you know, whenever when I will handle the issue of the imaging of the sella, then you know some of the pituitary tumors are invasive, and they destroy the cellular floor and they invade or extend into the sphenoid sinus, like this invasive pituitary adenoma, which has extended in the suprasellar area and also invaded the maxillary sinus. Thank you very much. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyidina Muhammad wa ala alihi wa sahbihi wa sallam ajma'in.